I'm very pleased to be able to talk with you about this um, very difficult kind of combination of psychiatric problems um, along with dementia. And so, um, as you've been told, I'm a geriatric psychiatrist. I've been practicing for now 36 years, and I'm the training director of our residency. I have no disclosures, as you've heard. So what I'm planning to talk about today is to touch on these four items. So psychiatric disorders predating dementia, confounding and coexisting psychiatric disorders with dementia. We'll talk about the behavioral and psychological symptoms of dementia, and then some treatment implications. As you know, that dementia is characterized by deficits of cognition, including impairments of memory, of processing, speed, of language, of attention, and executive functioning. It's very common, and it's becoming more common. They're anticipating 150 million people battling dementia by 2050. There's multiple types: Alzheimer's, vascular, Parkinson's, Lewy body, frontal temporal. And there's various risk factors of these different illnesses. We know there are some genetic factors. In specific with Alzheimer's, there's a small group of people with Alzheimer's that have this very high genetic load having to do with this amyloid precursor protein. There's environmental factors: smoking, anticholinergic use, demographics, lower education attainment, physical inactivity, medical diseases, including hypertension, cerebrovascular disease, some infectious disease are risk factors, but psychiatric conditions as well are risk factors. Well, I'll go through a number of psychiatric illnesses, and now these are associations, and again, associations doesn't mean cause and effect, but clearly seems to be connected to risk factors. So bipolar mood disorder. So bipolar mood disorder, people that struggle with periods of severe depression, as well as periods of elevated mood or mania. And about 2% of the population experience this. Dr. Zhao and others found in their research that up to 3 times greater risk of dementia than the general population. In specific, frontal temporal dementia seems to have a special connection to bipolar illness, and particularly the behavioral variant. And if we think of part of what frontal temporal dementia is personality changes, emotional changes, impulsivity, those kind of things, which again has some overlap even into when we think of manic activities or mood changes. So there's overlapping symptoms. The later the onset makes us really think about whether or not this is even a prodrome. But for a number of the case reports, the transition has been over decades. And again, another study by Mendez showed a significantly higher rate of bipolar illness in patients with frontal temporal. So again, if 2% of the population, and then now 10 to 11%. There's some shared genetic risk factors and risk variance with these two populations. The other connection of bipolar illness has been with Parkinson's disease. And And there was a very large Taiwanese national database study that showed significant increase in bipolar patients to go on to develop Parkinson's. There's another study by Nori, again, gigantic study, 125 million, that found that the diagnosis codes of memory loss, MCI, were most connected to Parkinson's and bipolar. There's some evidence to support that having bipolar illness is connected to accelerated aging of the brain, including functional and cognitive decline and changes in ventricular volume. The more episodes of mania that you have has been correlated with increased atrophy in the brain, especially prefrontal, temporal cortex, hippocampus, and amygdala. So again, thinking back to that frontal temporal picture. Depression and dementia. So overall, 10 to 15% prevalence lifetime with depression. So there's 264 million people worldwide have experienced depressions. The relapse rate, the recurrence rate is very high, as you can see. So again, you're going to hear this several times, but so is this comorbid? Is this a risk factor, or is this a prodrome? And it appears to be probably all of the above at different times. So here's some studies. In the Framingham Heart Study, as well as Santa Barbara and Stanford, found increased relative risks in patients with depression to go on to develop dementia. The onset of the first depression seems to be an important factor. The earlier the onset, so it's almost bimodal too. It's like that. So an early onset of depression carries a risk of about 2 times, according to Dr. Bennett, but also very late first onset depression has a particular connection to dementia. And I guess with this in particular, I think that this often is a prodrome. That if I've never had depression in my life, and now in my 70s, very first onset, that cognitive concerns are very much part of the picture. We do, as we've said, we do need more studies, as well as the impacts of treatment. Is effective treatment, helpful or not in preventing this risk? Anxiety and dementia. So this includes anxiety symptoms, so like generalized anxiety disorder, panic disorder, social anxiety. As a whole, anxiety is extremely common. So lifetime prevalence of anxiety, 34% of the population. And a number of studies have showed some increased risk of dementia. So the same Santa Barbara study showed some increase. In the UK, they found a significant increase, and so in nearly 1 million patients, new onset anxiety later in life, so at age 50 or on, had double the risk of Parkinson's disease. Again, prodrome, more research. Post-traumatic stress, about 6% of the population experience post-traumatic stress. Veterans with PTSD Yaffe has found that are 2 times more likely to develop dementia. If you combine PTSD and POW status, it jumps even further. Obsessive compulsive disorder. So again, in the general population, 2 to 3% lifetime prevalence. And there's a lot of comorbidity between anxiety and depression and OCD. So we're kind of blurring some of these risks. There's case reports. There's not big studies, but smaller studies suggest that there could be a higher prevalence. Late onset OCD, that can have a lot of blurring between the symptoms of frontal temporal dementia because rigidity and perseveration are, those are some of the classic things of early frontal temporal dementia. Well, so again, so you can see that those overlap. The Taiwanese large study again did show increased hazard ratio. A similar theme again to me. I think late onset is a different picture than early onset. E. So in children, young children, 3 to 12, 8% is the prevalence. Adolescents, 12 to 18 years old, is 5.5%. And adults, about 2 to 4%. Studies in this area is mixed. Some of them have an association with some increased risk of Lewy body dementia. Becker, in a systematic review, felt there was a clear increased risk in vascular dementia. Large cohort study found an increased hazard ratio with dementia, although when they culled out these confounding psychiatric illnesses, it wasn't as dramatic. Again, also like OCD, ADD commonly is comorbid with multiple psychiatric conditions, particularly anxiety and depression. Autism spectrum. So there's about 1% of the population experience autism. There's very few studies. In fact, this is really mixed. Oberman even thought that Asperger's, so a milder form, was potentially even protective. That really hasn't held up in other studies. Other studies show that there is some increased risk. There is no protection. Medicaid data, just by diagnosis code, patients that carry a diagnosis of autism do have a 2.5 times increased likelihood of then having a later dementia code. Down syndrome, I think we're all familiar that there's extremely high risk, that Alzheimer's, in fact, it's eventually 100%. Schizophrenia. So schizophrenia has a lifetime prevalence in the general population of around 0.5 to 1%. Many brain imaging studies over the decades have shown a lot of structural changes that are happening with patients that have schizophrenia. These are probably the most dramatic changes that you're going to see of the different psychiatric conditions. The dendritic spine abnormalities, these are crucial in plasticity and learning and memory. Decreased cortical gray matter volume, increased ventricles, white matter changes, reduced volumes in hippocampus and thalamus and accumbens. So just multiple areas of the brain are substantially abnormal in patients with schizophrenia. In this study, 2.8 million were followed over 18 years, and patients with schizophrenia had double the risk of developing dementia. another very large study that at age 66, the controls and patients with schizophrenia, you can see, was dramatically different. And then as they aged, it got even more striking, that much, much higher risk of dementia with patients with schizophrenia. And the cognitive deficits that patients with schizophrenia experience, they're very, very similar to developing dementia. And the more severe their psychotic course, the more times they've been psychiatrically hospitalized, the greater the risk of dementia. Both in the way on the onset of dementia comes faster, the rate of decline and the severity are all connected to how severe the psychotic course has been. There's clearly a dramatic increased risk in schizophrenia with dementia. Now, why? Well, it's not connected to the typical genetic markers that are looked for with Alzheimer's. Patients with schizophrenia do not have those. I think many people believe that schizophrenia, although it's treated by patients with psychiatry. 150 years ago, it was neurology that was treating this, and the initial terms, dementia praecox, and these early terms, that is schizophrenia really another one of these neurodegenerative diseases like Parkinson's and like Alzheimer's and like others, but that it presents earlier with psychiatric conditions as it progresses. I tend to believe that's the case. That as a group, they tend to have lower cognitive reserve, which was a risk factor. They have, as a group, patients with schizophrenia have more vascular risks. Remember, we talked about those white matter changes earlier, so that would be a connection there. Patients with schizophrenia have an inordinate degree of smoking. In fact, for decades, it was virtually 100%. Of patients with schizophrenia smoked. And it's curious, there's a number of questions about that. There's, the nicotinic receptor actually probably does help reduce some of the side effects of especially our earlier antipsychotics. It probably reduces akathisia or restlessness. A heavy smoker will metabolize antipsychotic medications at 2 or 3 times the rate, so they have less in their system, which can reduce side effects. It also reduces the benefit. But there's just this has been a connection for decades and decades. And then metabolic syndromes, that patients with schizophrenia are many of our primary treatments are medications that have and can impact our blood sugars, our lipids, and so again, getting back to the cardiovascular risk. So at smoking, increased cardiovascular risk, then we've got the combo of probably a neurodegenerative condition that is then doubly whammied by these other events and the small vessel events. Does that make sense? In New Zealand, so there's a 30-year study of 1.7 million New Zealanders, and they came up. Dr. Richmond Record they found more associations with mental disorders in general, broadly, and subsequent dementia that was stronger than any other medical disorders. So clearly important connections. So now, more broadly, why is this? Well, we don't know. Increasingly, this idea of inflammation is being is being pursued in all sorts of different medical and psychiatric conditions. Is that part of the events that are happening? We've already talked about this relationship of psychiatric disorders and cardiovascular disease. That there is an increased connection between poor health behaviors and psychiatric illness. Again, confounding our vascular risk. That as a group there's lower cognitive reserve, and there's great stress in experiencing a manic episode and experiencing a severe episode of depression. I mean, these are difficult illnesses to battle, PTSD, etc. So we're not sure that all of these are likely some confounding factors. Now, so when a person battles these psychiatric illnesses and then develops dementia, then we get, again, these kind of overlapping symptoms then, and as it emerges and progresses, this gets very confounding. In the DSM world, so that's our Bible in psychiatry of making diagnoses, that as a whole, when it comes to anxiety, depression, and different symptoms, much of those diagnoses traditionally go by checklists that you are getting subjectively from the person. So do you have XYZ? You know, how is your, and so subjectively reporting. And so things like the PHQ-9, the GAT-7, so these are, PHQ-9 is a very common instrument that's used in like by family medicine and primary care to screen for depression. It's the 9 diagnostic symptoms of depression, you know, sadness, tearful, loss of appetite, less interest, maybe suicidal thoughts, etc. You know, and this checklist, and over the last 2 weeks, mild, moderate, severe. GAD is a similar checklist for a screen for anxiety. Well, if I have cognitive impairment and I'm supposed to be telling you how I've been feeling as a whole over the last 2 weeks, I mean, this is not an accurate screening tool. And even earlier today, the nursing homes still use it. I mean, because the government mandates they have to screen with something. And I got a PHQ-9 on my 95-year-old patient that has profound dementia, and yet they're asking him these questions, and it's just not reliable. There's a number of alternatives. I'll just talk just briefly about the neuropsychiatric inventory. The NPI, what that does is that interviews the caregiver. Okay, so what does the caregiver, how do they report the patient's symptoms over the last month? And then there's a scale, from never to very frequently or severe, and of these different areas. And this has been around for decades. It's highly used in the research world. It has these 12 domains, okay, delusions, hallucinations, agitation, depression, anxiety, euphoria, apathy, disinhibition, irritability, aberrant motor behavior, sleep disturbances, and appetite disturbances. And so then it's lengthy, and it's detailed. And for my general practice and as I go see patients in the nursing home, I don't. It's not really that useful. It's too clunky to complete on on a regular basis, but it's a really good resource for staff and caregiver education, so that you can kind of tune into these, and we can use little pieces of it, especially if there's in these pieces in an individual person that we're seeing, that let's make it up, but let's say anxiety is the issue. Well, then we could use that subdomain and see how are those treatments, whatever we're trying to do, is that making a difference? This is an example then. So I just picked out the apathy component, and so you would ask this initial question of the caregiver, or the nursing staff. It would be in a facility, and then if yes, then you can see that there's some more specific questions to try to ask, and then to rate them on these scales. In the research world, there's fees for it, but it's free for non-commercial use, so it can be downloaded. So, in my world as a geriatric psychiatrist, and like I say, for decades, especially consulting to nursing homes, these are the most common reasons that I am consulted. And so the term behavioral and psychological symptoms of dementia. So you'll see, this BPSD, not PTSD, but BPSD, patients with dementia, 90% will experience some of these symptoms at some point. So here's this all this psychiatric overlap to what we were talking about earlier. So depression, anxiety, irritability, paranoia, hallucinations, verbal or physical aggression, apathy, disturbances of wake cycle. And these cause great havoc. They greatly reduce the quality of life for the patients and the caregivers. They increase caregiver burden. They increase the risk of elder abuse. The caregiver burden, as much as 34% of caregivers were experiencing depression, 44% were experiencing anxiety in this research study. Increases the costs dramatically. Increases the rate of institutionalization. I apologize, this is a little bit blurry, but so overall, the most common in general symptom is apathy, but followed by depression and aggression, sleep, and anxiety. You can see that big bunch. Now, when we break this down, so normal cognition, and the way you'll read this is no symptoms. So over 80% no symptoms. Mild cognitive impairment. Okay, still over half no symptoms. A third have one or two of these symptoms. And 11% will have three or more. And so mild, moderate, severe, not surprisingly, as we go through, then as dementia progresses, now we have a large number that are experiencing three or more of these symptoms. And if we combine the two, then you can see that we're up to very high rates of these symptoms. But one more look at, so we talked about mild, moderate to severe. Okay, so the picture does change over time. So in mild dementia, the most common troubles will be more mood and apathy. Whereas moderate and severe, then struggles of delusions, disinhibition, hallucinations, and agitation. So you can see as it progresses, the picture of the specific symptoms does change over time. The type of dementia um, does shift the picture of these behavioral and psychological symptoms. Um, it's not absolute, but there's trends. Okay, so in with Alzheimer's, much more commonly in mild dementia, it's depression, anxiety, and insomnia that will be most experienced. Again, moderate to severe, as we talked about, hallucinations, delusions, aggression. Lewy body, which for this study is including Parkinson's, visual hallucinations, early, delusions, REM sleep behavior disorders. So in the night, reacting to the dreams that seem real, and anxiety. With vascular dementia, much more common picture of apathy, amotivation, and depression. We've talked about the frontal temporal dementia as disinhibition, um, repetitiveness, aggression, and but also can have apathy, and then in Down syndrome, a variety of these behavioral symptoms. Why do we have these various behavioral and psychiatric conditions as part of dementia? There's probably a number of different factors. Some of them are potentially reversible. So in an infection, a recent stroke, we can't reverse that, but we can at least point to that pain that's not controlled. Constipation in a person that can't communicate about the constipation, urinary retention, dehydration, those can be causes for, not for the dementia, but for the causes of acute behavioral changes in a person with severe cognitive impairment. Anticholinergic medications, pretty much any medicine you can think of that has dry mouth as a side effect or blurred vision, these are very troublesome meds to patients with dementia. SSRIs do have the risk of hyponatremia. There's lots of people that can take it without that, but there's a subgroup that are highly susceptible. Antipsychotic medications can definitely cause akathisia or restlessness, which can be mistaken for agitation. Parkinson's medications are famous for causing visual hallucinations, as well as some compulsive behaviors. Alcohol disinhibits and causes trouble. The patients with dementia also experience grief and loss or boredom. They come with their pre-existing psychiatric illnesses that we've talked about. Stressors that are going on that they may be aware of. Other factors, the role of the family and other caregivers, the more that those can be both kind of modulating or aggravating factors. So we'll go through just a few specific symptom. So I'll make sure I'm watching carefully for time. Okay, anxiety and irritability, that often that presentation, that might be worry, might be fearful about being alone, that the person may just essentially follow the loved one, fearing to have the person out of their sight, that they worry that they'll be abandoned, that they can experience catastrophic reactions, meaning some very kind of minor upset all of a sudden just becomes a huge calamity. Delusions and hallucinations. So many times, the married 50, 60 years, wonderful couple that all of a sudden The individual with dementia is now accusing their 85-year-old spouse that they're having affairs with these 20-year-olds, that they're misidentifying the family members now, that they or that they're that they're having these out and out visual hallucinations, especially with Lewy bodies and Parkinson's. Those visual hallucinations, it's interesting that in men, I've just seen many cases where the men will see very frightening things, snakes, alligators, that sort of thing, and will kind of strike out at them because they're very frightened of them. Um, it's not all, but I've had a number of women that have battled this, and they see kids, and they set extra places out at the table for them, and they're not upset about them. They're pleased that all these kids are coming over and things. And so it's very curious. The very same visual hallucinations for some were reassuring, and others were extremely frightening. So even when we talk about treatment, so if they're not frightening, what's the harm of setting out extra plates? Let's not treat that. But when they're swinging their canes at those dang snakes, then that's really frightening. Disinhibition, socially inappropriate, overly familiar. These wonderful, upstanding, the preachers and the pillars of the community that are all of a sudden saying things that they would never say because of that, typically the frontal injury, so they just don't have the filter. Laughing, pathologic laughing and crying, the pseudobulbar effect is especially classically in MS, but in frontal, in TBIs, as well as in ALS, that you can see this just kind of disconnection, that any kind of pleasure or any kind of emotion, the circuits are crossed, and so I'm crying, but I'm happy, or I'm laughing, but I'm sad. That they get disconnected. Most patients that struggle with dementia, as well as, as we get older in general, we lose smell and taste. But then it's much more marked in many patients with dementia. So then, so things don't taste good, so weight loss may be connected with it. Their frontal temporal may have overeating and craving, but for most others, it's the dwindles that we see in the weight loss. We have to be careful. Some of those meds that we're using to try to help slow the memory loss can add to GI upset weight loss. So we have to be careful about that. Depression. So patients with dementia that are struggling with dementia, they may fit some of these DSM criteria, but many times irritability is kind of more part of it than in a younger person with dementia. Their suicide risk is significant after the diagnosis of dementia, especially early. The more severe the memory impairment, then generally the suicidal risk drops away as they become more oblivious to it. As we've talked about, these self-report measures are just become increasingly unreliable. So we talk about apathy. That can just be really hard. It's hard on everybody, but especially hard on the families. All of a sudden, these loved ones just don't seem to care at all, and they're less affectionate, they're less motivated, they just don't engage, and so it's a very difficult psychological change with dementia. The aggression, a variety of both verbal and physical aggression, and that often is the point of overwhelming the caregiver's ability to take care of that patient there, to take care of that loved one at home. Sleep-wake cycles are very commonly disturbed. You've heard about sundowning, but the agitation at night, and then especially connected to things like Lewy body, these day-night shiftings that are very common. So how how can we try to help? So that as caregivers and as providers, are there contributing medical or environmental factors? Are there problematic medications? Is there pain that we're not clearly understanding? The very best research that's found that showed the most effective ways to help manage these symptoms is caregiver training, is helping to train and educate and support caregivers, which is, of course, what Alzheimer's Association is all about, right? Much more effective than any other kind of treatments that we can do. And I would say that caregiver training, that it includes in my world, in the nursing home, the providers, the nursing, the nurse aides and that sort of thing. Activity is generally helpful. Having some stimulation is helpful, as long as we don't want to overdo it. Music therapy can be great. Unhappily, we had this wonderful brass band that came to the nursing home. They were extremely loud, and they were overstimulating. Okay, quiet, soothing music is better. There's behavioral management plans to try to target the most problematic things, and when everything else fails, then there's some pharmacologic interventions, especially if there's dangerousness and significant aggression. It's not within the scope of this talk to talk about those today, but and the safe environment is so important as well. So just a couple slides on advice to family caregivers. And these are, I'll give you this reference at the end, but Dr. Walizek is really a wonderful publication that's aimed to care to the providers, so for physicians and nursing staff and providers, and I'll give you that reference. But some of these, as well as some of these earlier slides, come from his work. So be flexible. Don't take what is said personally. Try to still allow the person to have some control of things that are okay to be in control of. Be realistic. Unfortunately, as the illness progresses, generally more help is needed. When a person has a delusion or a fixed belief, it doesn't work to try to talk them out of it. Just validate that yes, that must be upsetting. Try to keep the responses simple. Give them time to respond. Try to be calm and positive. Try to be reassuring and encouraging. We know that it's hard on us, but try not to show it. Maybe to step back, reapproach. In your environment, have a routine. Schedule the challenging things whenever the time of the day is the best time for them. And try to do pleasurable activities, but don't overschedule, don't overstimulate. Big crowds, big family gatherings, family reunions are disasters for people with a lot of dementia. Now, if you could be in a corner and then just have a few people come over here and there, but don't overstimulate. Figure out some meaningful things that they can contribute. Something that's helpful. We have to care for the caregiver. As a caregiver, don't forget to eat healthy. Don't forget to exercise. Don't drink too much. Try to maintain sleep. Continue to go to your medical appointments. Watch for signs of burnout. Take breaks. get home health care, consider adult daycare, consider some sort of respite. All support groups, Alzheimer's Association, here in Fargo, the Memory Cafe and others, to schedule activities with families and friends. So it's just really important. Now, when it comes to psychiatric illness, when I've had this depression over all my life, I've had bipolar illness or schizophrenia, that it's still important to treat those, although we have to be careful that some of those meds may have anticholinergic loads, so we may have to shift the type of treatments that we do. If I'm 90, even if I have dementia, if I'm bipolar, I can absolutely become manic. I can absolutely have a relapse of my psychosis. Those are lifetime treatments that you really need to continue. Here's the big question. So can psychiatric treatment alter the risk of dementia? Because we talked about this, and the answer is we're not sure. There's some interesting things about lithium. Lithium seems to have some neuroprotective effects. Is it a direct neuroprotective effect? It's been a failure to just as a treatment for Alzheimer's, for example, but in the bipolar patient, by preventing these extreme cycles, can that be helpful? Early studies in the 50s, 60s, 70s found that there was an increased risk of dementia on patients that were treated with antidepressants. Although, to separate out again, because we saw an increased risk of depression itself, but these early meds were highly anticholinergic. They had a lot of side effects. Our more newer meds we can pick many of them that have minimal to no anticholinergic. So we believe it's important to treat. The treatment responses are less robust and less the antidepressants for depression in a patient with dementia don't work as well. They're still worth trying, and then they're more likely to experience side effects. Lastly, I just want to make sure that anything with PM, Tylenol PM, acetaminophen, ibuprofen, all of these PMs, these are toxic to patients with dementia because of the anticholinergic load. So this is what we've talked about today. Dr. Walesak, to providers, I would strongly recommend this book. It's published about 3 to 4 years ago. It's extremely handy. It's very readable. It's well thought out. So that's what I have for today.